So share screen and yeah, we'll just adjust this. So we are going to discuss the basics and the key trials. So I just briefly wanted to talk to you also about the number of young patients with colorectal cancer that we are seeing in our clinics. So I think as oncologists, whether I've discussed this before, whether you are surgical, radiation, or medical, it is our responsibility to try and detect cancer early and also create public awareness. So I have this thing for preventing cancer, and I encourage you to use it as well. So I won't go in details about it because it is self-explanatory. But screening, S for screening, it's A, B, C, D, E, F for cancer prevention. And if you want, we can take a separate class on it based on the evidence that is there for each of these strategies. Screening, the reason I put it here because it's very important for colorectal cancer. Oh, sorry, I lost my slides. Yeah. So during lockdown, I think in COVID times, we stopped the screening because we wanted to keep healthy people at home and not use the healthcare resources for screening. And all the international guidelines and societies and national societies recommended that we stop screening. But now that we know that, this is going to go on for some time, I think we have to continue. Very important that you prioritize the downstaging of disease. Now, this slide is very important because, you have healthy, abnormal, pre-invasive. It is mainly the cancers with the pre-invasive component, and those are breast cancer with ductal carcinoma in situ, cervical cancer with cervical intraepithelial neoplasia, and with colon cancer, colorectal cancer. So you have the pre-invasive stage, so that lends itself to screening, and also head and neck cancer where you have erythroplakia and leukoplakia. So if you diagnose cancers early, obviously the cost is less, and if you diagnose it late, the cost is more. Colorectal cancer takes about 10 to 15 years. So very important that, for patients or general population who are, or if you have colorectal cancer patients, make sure you take a history for family history for that patient, because you have two pathologies. You have familial adenoposis polypi, and you also have hereditary non-polyp HNPCC, which you could send the patient for genetic counseling if there is family history. And also in the family members that come with the patient, talk about colorectal cancer screening, because as we are becoming more westernized, the incidence of colorectal cancer, and especially rectal cancer, I've seen in young men and women, is increasing. And it is a very cost-effective, cheap, simple test. So in UK, if you're above 55, most people get a pot from the GP. So very important also to check that how your lab does. If it does by GAIAC method, you need about 6 samples based on the evidence. If it is by fecal immunochemical method, you just need to have 1 sample, and this could be done annually. Of course, the gold standard is colonoscopy, and if you do have a strong family history, then that patient should undergo genetic counseling and maybe the APC gene or the other gene tests as well. So again, this is the evidence as to why screening does reduce cause-specific mortality in colorectal cancer. So that was just about 2 minutes on prevention. Now, when we come to rectal cancer, it's slightly complex. What assessment that you need to do for rectal cancer? We need to know the depth of invasion. I'm going to talk about it. Are the lymph nodes involved? Is there extramural vascular invasion? And I'll talk about that as well. Is the CRM? So you will hear these words, the circumferential resection margin and the mesorectal fascia, or the MRF, is threatened. And one can assess that on the MRI scan. And also very important for low and mid-rectal cancers, is it possible to do sphincter preservation? And how should the lesion be removed? Should it be done by a gastroenterologist? Should it be done by a surgeon? And what should be the steps of the surgery? Should the patient have a temporary stoma, or would the patient need a permanent stoma, which actually would be life changing for the patient and would affect quality of life? And the other issues that you have to address in rectal cancer, so there are a lot of issues. That's why we'll do this class in 2 sessions, is whether you do upfront surgery. Could you mute yourself if you are unmuted? So upfront surgery versus how do you select patients for neoadjuvant chemoradiotherapy? And if you want to give neoadjuvant therapy, what should you give? So now I've put here short course versus long course, but versus there is neoadjuvant chemotherapy or versus total neoadjuvant therapy, which includes everything. So how do you select these patients? Pre versus post-surgery radiotherapy, whether you should do immediate surgery post-treatment or whether you should do delayed surgery, and what is the time that you need to do a staging assessment? What is the role of consolidation chemo and adjuvant chemotherapy? And if a patient achieves a complete response post all the treatment, what next? I think in breast cancer, we answered that question, that even if you attain a clinical complete response, the patient must undergo breast conserving surgery or mastectomy, whatever, based on the staging. So it is not possible to observe them. In rectal cancer, but in breast cancer, it is possible to do reconstruction, and with the oncoplastic measures, there is amazing cosmesis that is possible. But in rectal cancer, the implications are huge, because if it's a low rectal cancer, the patient may be left with a stoma for life, and it does affect quality of life. So the implication of complete response is very important to see whether it is possible to avoid surgery at all. And how do you select patients for adjuvant chemo versus chemo radiotherapy? So staging, again, a reference level and method in the chat. There is, yeah, okay, thank you. So, you have these various terminologies, and you get a report from the endoscopist, which is different, and the distance from the anal verge is very important. So whether it's a low, mid, or upper rectum tumor. So if you do it by MRI, usually we calculate it from the anorectal junction. But if it's a clinical exam or a rigid proctoscopy or flexible endoscopy, you would calculate the distance from the anal verge. So that's why in MRI, up to 4 centimeters is taken as a low rectal cancer, 4 to 8 is mid, and 8 to 12 is high or upper rectal cancer. And I would say that MRI is probably more accurate compared to the other modalities, but we can discuss this. So T staging, again, when you see the report, for a surgeon, it is very important, and also for a gastroenterologist, for the where the tumor is, whether it's anterior, posterior, whether it's central, lateral, whether it's pedunculated, annular, semi-annular, whether it's obstructing. Very important that, if it is obstructing, the patient may need a covering stoma to get him through the neoadjuvant chemoradiotherapy. So very important that when you see a report, or even if assess patient symptoms, that whether the patient has any signs of obstruction or passing stools is very painful. If it's a low rectal tumor and there is anal spasm, the patient may be in a lot of discomfort and pain. So in that situation, probably if you're planning to give neoadjuvant treatment, doing a covering stoma before you start a neoadjuvant treatment would actually be better for the patient. So all of these things that you will be looking at. And for T staging, an endorectal ultrasound is very good, and also an MRI scan as well. So the other thing I think one has to look at is the submucosa. Whether it is visible at the invasive edge, what part of the submuscularis propria is involved. Again, the MRI should be able to delineate that. So, and also in T3 staging, whether it is T3A, T3B, it's very important for the prognosis of the patient. And this is one of Professor Gina Brown's slides, where she has in the Mercury study correlated each of the MRI findings diligently and meticulously. She was there at most of the grossing that was done for that patient who'd had the MRI. And she has correlated the MRI with the pathology quite accurately. So I think MRI should be the gold standard in rectal cancer patients. So you look at the subclassification of T3, whether there is disruption of the submucosa, and what level of the submucosa is preserved, because the prognosis is different. So if you have no involvement of the muscularis, or the microscopic invasion is less than 1 millimeter, or invasion is less than 1 millimeter, like T3A, the prognosis is quite good. So up to 1 to 5 millimeter invasion as well is quite good. That would be T3B. So this has not actually found its way in the TNM classification, but if you look at most of the studies which are MRI based that have come out of Gina Brown's group from the Royal Marsden, you can see that it does have a prognostic implication, especially if it is T3C or T3D, which is 6 to 15 millimeter or more than 15 millimeter beyond the muscularis propria. So very important that, when you have an MRI report, and if there is any doubt, because this actually, all of this helps you in deciding whether your patient can go for upfront surgery or the patient needs a neoadjuvant chemoradiotherapy. So if it's a T3C, T3D, that would make you think towards some form of neoadjuvant chemotherapy. So these are the relevant features that you would look on MRI pelvis. And if you don't have them, I would, like Tata Hospital and the ICMR colorectal guidelines, and again, the synoptic reporting templates that we have, will talk about these features. CRM, whether the patient has EMVI, the arrow is pointing towards, tumor in the blood vessel, that's extramural vascular invasion. Site of the tumor, anterior, lateral, central, whether the levators are involved or not, and the T and N staging as well. So for staging of rectal cancer, my gold standard usually is I do a CT chest, abdomen, and MRI pelvis, because if you do a PET CT scan, then you have to still do an MRI pelvis. So if a PET CT scan has been done, that's fine. You must also ask for an MRI pelvis, unless the PET CT scan, shows a large nodes in the pelvis, which is not going to change your treatment strategy. And it's clear on the CT component that, you can see that the mesorectal fascia is involved, or there are quite big lymph nodes which are going to dictate your neoadjuvant strategy. Then, you can reserve the MRI pelvis to when you stage the patient about 6 to 8 weeks after the end of neoadjuvant therapy. So now that I just wanted to just have 2 slides on this. Upper third rectal cancer, there are a lot of papers on it. You can read them as well. Should we treat them as colon cancer, or should we treat them as rectal cancer? Now, it's very clear from quite a few studies that upper third rectal cancer, if it is above the peritoneal reflection, you would treat them as colon cancer, and you would consider those patients for upfront surgery and not consider, based on the TN staging, you would not consider them for neoadjuvant strategy. And again, these are the papers that are the evidence. And I can email you these slides at the end of the lecture, and put your number if you want on the chat group, so that I can add you to the WhatsApp group, because it's very difficult to email slides individually. So for rectal cancer, you will hear a lot about circumferential resection margin. So you have the tumor, you may have the blood vessels, and you have the mesorectal fat. So again, it may be A, B, or C. And in B and C, the tumor is actually touching the mesorectal circumferential resection margin. And in A as well, it's there in the mesorectal fat. So each of these are actually means that the circumferential resection margin is involved. And more than 17,500 patients with the CRM positivity ranging for up to 33%. This has been linked to higher locoregional relapse, distant metastasis, and survival. Mainly the studies, the trials have come from the UK MRC group. So the other question is, what is the distance to CRM that is safe? So whether it's 1 millimeter or whether it's 2 millimeter, and you will hear different things actually. And again, this is from Gina Brown's group. She has shown that that 1 millimeter on MRI, you can see the curves. The blue is 1 millimeter, which is doing quite badly as far as local recurrence is concerned. So one, and the rest of them are quite on top. So 1 millimeter on MRI is the only distance that predicts the risk of a local recurrence. And this has been validated by Dr. Brown in prospective trials. So again, MRI is very, very important, I think, in the management of a rectal cancer patient to try and do the best for your patient, because you want to know what is the risk of CRM positivity and the extent of the extramural tumor so that you can plan your treatment accordingly. Depth of invasion, I think I talked about the submucosal invasion. Why is it important? So if it is superficial 1/3, the risk of nodal metastasis is 2%. If it is 2/3, it's 8%. But if the depth of invasion is more than deep, it's 1/3, the risk of nodal metastasis is more than 20%, up to 23%. So that itself, SM3 is a very, I would say, a hard indication for neoadjuvant chemotherapy or chemoradiotherapy. So again, these are the various high-risk features which you would look for. And I've put both the trials because slightly different. One says 1 millimeter, 2 millimeter. But again, like I said, Gina has shown in prospective studies that, 1 millimeter on MRI is highly predictive if it's within 1 millimeter of local recurrence. And the other high-risk features are low-lying tumors, as we've said, or tumor extending more than 5 millimeter into the perirectal fat, or T4N2 disease. Now, is it possible to identify potential CRM positivity? Yes, it is. And and this has been again prospectively correlated validated as well. So with MRI, you can look at the low rectal cancer surgical plane and see if it is unsafe. If it is unsafe, by that I mean that the CRM it looks positive, or if there is invasion of the anterior quadrant of the rectum, less than 4 centimeter from anal verge, or MVI. So if you have none of the above, the chances of pathological CRM positivity is only 1%. We have all of the above, the chances are 60%. So, and the positive LRP, like I said, the chances of R1 resection are about 25%. So again, distance from anal verge and local recurrence rate is very, very important. That if the distance, if it's a high rectal tumor, the radiotherapy does patients, but it is not highly significant. Could you please mute yourself, whoever is unmuted? Actually, I have it on that people should mute themselves when they come in. If somebody can see who it is, if you could tell them, thank you. So what are the indications of neoadjuvant therapy? How do you select patients? So, I put up a lot of questions at the beginning, and we can discuss.
My patient voice.
if there are any clarifications. Main indications are,
Ma'am, excuse me, ma'am, you can mute the other participants.
yeah,
Host can mute.
I have done that actually already. So do I have to stop? So where do I go? Remote control. I go, yeah. How
ఆ
do I
టూడే ఎలా ఉన్నాడు
participants?
రెండు కాళ్ళు మీద పెట్టేసి
Yeah, so I've done that. Yeah, thank you. So, so you're talking about indications for neoadjuvant therapy. So we've talked about SM3 invasion, which is a hard indication, extension to pelvic sidewall or pelvic lymph nodes. Again, tumor budding, and on biopsy, mucinous subtype is actually a soft indication. N2 disease, that is nodal metastasis in the mesorectum, EMVI, lymphovascular invasion, and especially if it is close to the CRM, is also a very important indication. And I think the other thing is the anteriorly, we talked about anteriorly placed tumor at or below the level. For a surgeon, this is very important. In a large male with a narrow pelvis, is predictive of a technically challenging discussion and again dissection, and it's been shown in quite a few studies with a 30% possibility of a CRM positivity rate. So you must keep track of that and consider the patient for neoadjuvant therapy. And I've put surgeon's learning curve as well, because again, that is very important. And the sphincter preserving surgery, very important for quality of life for our patients. So this is a slide which I show in every talk for any treatment. Toxicity versus efficacy. As oncologists, this is something that we have to talk, and we must talk to every single patient. What is the, even if the patient says to you that, doctor, you decide what is best for me, it is still important that we actually tell them what are the risks and what are the benefits, what are the toxicity, what is the and what is the, what is the upside. You may have a patient for example, just coming to rectal cancer. Yes, PATH-CR may lead to better outcome and may actually lead to sphincter preserving surgery, but there's only one trial, randomized trial, which has shown that, and we'll talk about that. But the long-term side effects, at the Marsden, when I was there, I used to do a proctitis clinic with Jarvis Andreev. So patients who'd had short course radiotherapy about 5 years ago, 10 years ago, would still be coming to the clinic, and we'd manage them with steroid enemas and quite a few other things that I learned in managing proctitis. But at that time, I realized that how important unintentional release of stools is for patients, how embarrassing it is. And all of these affect quality of life. Yes, you may have cured the patient, but they're still coming to you 5 years later with these problems. So one has to keep these in mind and talk about it. Sexual function is affected with long course and short course chemoradiotherapy. Anal blood loss is there because of telangiectasias that may happen. Stricture at the anastomotic site, femoral head fractures, second cancers, and neuropathy relating to oxaliplatin. So again, very important that, patient is told that some of these side effects may be irreversible. So this is just a snapshot view, how we have completely changed rectal cancer treatment. So in 1980s, we knew that adjuvant, we would consider most of these patients to decrease the risk of local recurrence for adjuvant chemoradiotherapy. And we knew that it improves outcomes compared to surgery alone. Then this was the NSABP and the NCCTG trial. Then a decade later, that is in early 90s, when I started training, we had the Dutch TME trial, and we had the German trial, and the NSABP trial, which showed that, rather than giving radiotherapy post-operatively, we should bring it pre-operatively, and I'll talk about that. And then We also learned that between 2012, I think, we learned that 5-FU, that capecitabine is non-inferior to 5-FU. Because we use fluoropyrimidines in pancreatic cancer, in rectal cancer, in gastric cancer. We use fluoropyrimidine as a radiosensitizing agent. So, it actually increases the efficacy of radiotherapy. And my feeling is that capecitabine, and also there is one study which shows that capecitabine very likely is better than 5-FU. And if you are going to discuss chemoradiotherapy, capecitabine, I feel, is better than infusional 5-FU, and infusional 5-FU is better than bolus 5-FU. So if I had a choice, I would actually go for capecitabine. And also we learned that, oxaliplatin has no benefit. So we'll talk about these trials as well, because I think for your exams and also for when you talk to patients, it's important to know the results of these trials. And then, now in this decade, we are talking about organ preservation. We are talking about neoadjuvant therapy, about total neoadjuvant therapy. I'm going to discuss this decade next week, because I want to go through how we have arrived at this in the last two decades. Sorry. Yeah. So pre versus post-op radiotherapy, this was the German trial, which actually a huge number of patients were randomized, resectable rectal cancer patients were randomized. And by the way, if you need any of these trials, I will add you to the WhatsApp group. If you need any of these papers, I have all of them. I can send them to you. I think it's easier for me to WhatsApp everybody, because rather than individually emailing, I've realized, because I forget. So this is a note that this is a long course chemoradiotherapy. And, when you look at long course, you will see that there are a lot of dose differences slightly between Europe and US. So this is a long course 5-FU preoperatively, followed by a 6-interval and then radical surgery, followed by upfront surgery, and most patients got adjuvant therapy. So pre versus post-op, the dose of radiotherapy was slightly on the higher side. The primary endpoint was overall survival. The second trial is very similar, which is a short course radiotherapy trial and is known as the Dutch TME trial. 1,800 patients, 25-gray radiotherapy given over 5 days. 1 week later, patients underwent surgery, because at that time, the thinking was that, after short course radiotherapy, if you wait for too long, the morbidity is higher because fibrosis sets in. So it's better to operate as soon as possible. So versus upfront surgery, and the primary endpoint was local control. So both of these trials were published in New England Journal of Medicine. And just to show you, I just wanted to show you on one slide the German versus the Dutch trial. And in both the trials, you can see that whether it was long course or short course, with the use of preoperative radiotherapy, there was a significant decrease in local recurrence. Almost half, 13% versus 6%, and 8% versus 2% in the Dutch trial. And also the German trial is the only trial which has shown a statistically significant increase in sphincter preservation among patients receiving preoperative chemoradiotherapy. But sadly, both these studies have published their update, a few years later in Annals of Surgery and Journal of Clinical Oncology. And as you can see that none of these trials have led to an overall survival benefit or a disease-free survival benefit. And most of the rectal cancer studies actually have not led to an overall survival benefit. But again, for quality of life, pathological complete response and local recurrence or clinical complete response is a very clinically meaningful endpoint. This was the other study done in UK, huge number of patients, again, short course given pre-op followed by surgery versus surgery followed by long course chemoradiotherapy. And as you can see, even though the doses of radiotherapy are slightly different, you can still see that the loco-regional recurrence was much better with preoperative radiotherapy, and about 12% patients in this trial who had CRM positivity. And the survival was also, and the disease-free survival and overall survival was better for preoperative radiotherapy, disease-free survival significantly better. I think the key things to remember is, if we discuss cases, or if you bring cases next week, we can discuss, how you choose short course versus long course and why you should choose one over the other. So compliance, frailty is very important. So I'll just give you an example of two patients I had very recently here last year. So both of them were in their 80s. And so one was 88, 85, one was, I think, 84, very, I would say mid 80s. One of them was playing golf till about a week before and presented with a CRM positive T3 CRM positive N plus MRI staged cancer. The other one also had an indication, a hard indication for neoadjuvant chemoradiotherapy, CRM positive as well. Now, on one patient, we decided to go for long course because chronologically, though he was 85, biologically, he looked as if, he was in his 60s. He was a fit gentleman. He was playing golf, was not frail. So we went for long course chemoradiotherapy, and he attained a clinical complete response and then went on to have surgery. The second, which showed a pathological complete response. The second patient had a short course chemoradiotherapy, and we operated. What we did was if I do give, so we waited for 6 to 8 weeks, but in that 6 to 8 week interval, I gave him capecitabine 2 cycles while we were waiting. And he also had a pathological complete response, which is, which was very lucky to have these two patients who were in their mid 80s do so well with these two different strategies. And we will talk about today also whether, I could have just observed them.
Ma'am, short course with the chemo, was it with the concurrent chemo or was it after?
No, after. So afterwards. So they had short course chemo, and then about 2 to 3 weeks later, I also, because normally if patients are above 75, I also do DPD gene mutation testing because again, it's because if patients have this positive, then the risk of cardiac toxicity, especially coronary vasospasm or grade 4 neutropenia, grade 4 diarrhea, is quite high. In fact, when I was in Tata, we published 3 case reports with grade 4 toxicity with the fluoropyrimidine with Samir Rastogi, who's now at AIMS. And so this is something, and most of the patients who end up having this grade 4 toxicity are usually elderly. Can happen in a young patient as well, but in elderly, you don't have to improve or get better if you have a grade 4 neutropenia or if you have grade 4 diarrhea. So, so I tend to do in most of my patients who are above 75. So the way we give it is I give short course. I'll actually talk about the studies as well, where they've given short course followed by interval chemotherapy. So I think all of these things are the things that you would look at. Cost is a very important factor as well, because long course and working in, whether you're working in Tata Hospital is different, or AIMS or Adyar or any of the regional cancer centers. But if you are working in a private center, it's a revenue driven model. So everything depends on the number and the fractions of radiotherapy as well. So if we go down, so now the question is whether you should go for short course or long course. That is a very important question. And these are the two trials which looked at in T3 tumors, looked at short course versus long course radiotherapy. And as you can see, that the local control was not significantly different. In fact, probably short course, it was slightly better. So if you look, the pink line, the short course, the risk of local regional recurrence is slightly better, but not significantly different. So we should not read too much into it. And similarly, you know, in the TROG trial, you can see that the local control is pretty similar, 5 versus 7%, 4 versus 7% between short course and long course. The overall survival, you can see the curves are literally on top of each other. Sphincter preserving, again, you know, how do you, so if your patient has a APR, or the patient does have a stoma. So if you look at both the trials, the Polish trial and the other trial, patients had quite higher stage tumors, T3N2, T3T4, up to 6 centimeter. The other trial had up to 12 centimeter. That's why the rates of APR are slightly different. But you can see the rates of APR in both the studies in the randomized trial are pretty similar. And like I said, they were all low tumors in Polish trial compared to the other one. Now, the next question we have is it safe to delay surgery? Because, you know, our thinking was we should operate within a week after short course radiotherapy. Otherwise, the fibrosis will set in and it will be quite difficult for our surgical colleagues to operate. So this was answered by this Stockholm trial. And patients were randomized to short course followed by surgery versus short course. They had an interval followed by delayed surgery versus long course followed by delayed surgery, which was usually 4 to 7 weeks. And as you can see, and you can look at the distant metastasis, there is absolutely no difference in all of the 3 arms with the delay in doing the surgery. So then the next question is, you know, you have this gap of 4 to 6 weeks after short course. Can you intensify, or even after long course, can you intensify the chemotherapy given with the, so no, we'll come to the question next. The other question is, can you intensify chemotherapy given with radiotherapy? So, you know, obviously as oncologists, when we learn that capecitabine is very good with radiotherapy, we want to add the second most effective drug, which is oxaliplatin. And there were 4 trials which did that, the STAR, PRODIGE, and all of these trials which are listed here. So they added capecitabine, they added oxaliplatin to either capecitabine or a 5-FU. And as you can see, that addition of oxaliplatin did not improve outcomes. So the PAT-CR rate, as you can see, has not been significantly different. It has been, just if you look at the German trial, it was 13 versus 17%. But other than that, there was, and this is the trial where you had most of the patients were able to have a sphincter preserving surgery with the neoadjuvant chemoradiotherapy. But there was one trial, which is the AVACROSS trial. I haven't put it here, which actually added bevacizumab as well preoperatively to neoadjuvant chemotherapy. And the PAT-CR rate was 36%. But the surgical morbidity was so high that has never taken on as a regimen for preoperative treatment. And actually either infusional 5-FU or capecitabine remains the standard of care, and this has not been practice changing. So when should you scan after chemoradiotherapy? So if you look at these pictures, I've borrowed them from Professor Gina Brown. So this is baseline MR T4 tumor going into the mesorectal fat. After 6 weeks, this has gone down and it's become T3B. And after 12 weeks, it's become T2. And then she has correlated with final pathology, and it was YPT2N0. So when should you do the scan actually? So there are quite a few trials which have looked into the timing. And this was the randomized trial, the GREEK-R6 trial, which looked at 7 weeks versus 11 weeks interval post completion of neoadjuvant chemoradiotherapy, what is the effect on complete pathological response rate? I think I'm going to stop in 4 minutes and we'll discuss some questions and then maybe take it on next week. And as you can see in this trial, there was no difference in pathological complete response rates. In fact, 11-week group had slightly more medical complications and worse rate of complete TMEs. We'll talk about what is a complete TME and how a pathologist can actually tell if the surgeon has done a good quality TME. Very important that you have a good pathologist who takes photographs of the specimen that have come out, so that you know as a surgeon what is the quality of your TME and how you're going to improve. At TMH also we looked at this, and I think it has a bigger study has been published after this, and we also saw that the pathological complete response, whether it was less than 8 weeks or more than 8 weeks, it was numerically higher, 23%, but it was not statistically different. Now, if you look at tumor response, the timing trial. So these are the 4 cohorts where, patients had had long course chemoradiotherapy. So in the first cohort, interval to surgery was 8 weeks. Then they added in 2 cycles of FOLFOX, 4 cycles, 6 cycles of FOLFOX. And as you can see, that the further you have gotten from the completion of chemoradiotherapy, 8 weeks, 11, 15, and 19 weeks, the rate of pathological complete CR has actually increased. So the thinking behind it is that the radiotherapy keeps working at downstaging the tumor even after 10 weeks or 12 weeks. So 18% versus 38. And I think these results of 38% we've only seen in chemo with Avacross study. So I think why are we trying to attain a path CR or complete CR? So it's in India, if you practice here, we all do, and most of our patients actually decline having a stoma. And a lot of times I've seen actually that patients are lost to follow up. They do not know once they have had a good response, once their anal spasm or the sphincter symptoms or bleeding has stopped, some of the patients actually disappear. So very, very important, when you go out in the community as oncologists, counseling is very important, that, that even if they are very anti-stoma and they want to discuss watch and wait, this is something you must bring into the conversation early on, so that, the patient does not disappear and then comes back with a horrible recurrence a year later or 2 years later. So, sorry. 4 strategies to attain CR. You can intensify neoadjuvant. We've discussed that. Adding oxaliplatin makes no difference. Extend the interval. We've discussed that with the timing trial. You can add chemotherapy during interval after CTRT. We've discussed that as well. And you can also give induction chemotherapy followed by chemoradiotherapy. We will discuss that with the trials that were presented at, there were actually 3 practice-changing trials presented at ASCO this year, Rapido, Opera, and the Prodige study. So this we've discussed, addition of oxaliplatin makes no difference. So the first trial actually for your exams, you must know the Leon study, the interval, the timing. We've talked about the time, the Grecar study, 7 versus 11 weeks, which is the true randomized trial. But the Leon study was the first one which showed doubling of path CR rate when you increase the interval from 2 to 6 to 8 weeks. And again, all of these studies, you must know at least some of the basics about these trials. And the third strategy was the timing trial. And again, you can give neoadjuvant chemo followed by chemoradiotherapy. We'll discuss that next time. So just in 2-3 slides, I'll finish this non-operative therapy. Can you avoid surgery for some patients who attain a complete clinical response? Yes, you can. Actually, let us stop now. It is 6:46. So I'm going to now go through the questions that you have, and you can wave your hand as well if you. So I have got your phone numbers. I will add you to the group. Great. Let me just go up. So I'm not able to. So why don't you actually unmute yourself and ask a question if you have, or if you have a case that you have seen that has been quite difficult, or any questions you have about what we have presented today.
Ma'am, can I ask one question?
Sure, sure. Please go ahead, Kanchan.
Ma'am, you said for pelvic lymph nodes, we give chemoradiotherapy.
Yes.
Why don't we operate these patients? I mean, why only radiation?
No, these patients do get operated. So this is
I
given
meant
as a
pelvic lymph node dissection, why it is not done?
So when the surgery is done, if the surgeons feel that the lymph node was involved, they would remove it if it was positive. But it would so these patients, we would consider them for long course chemoradiotherapy.
And so does that mean that even after neoadjuvant chemoradiation, we have to do that pelvic lymph node dissection if there is on a post neoadjuvant chemo RT MRI, there is the nodes have completely resolved and there are no new nodes seen. Still, we have to do the pelvic lymph node dissection.
Ideally, it should be done actually. Ideally, because there is no evidence that that you don't operate. But if you have done a good quality MRI, this is what we used to do earlier with the concept of watch and wait, and all of us being comfortable with watch and wait. Like if you asked me this question 4 years ago, I would say you should operate. But now with the watch and wait strategy, and we have quite a few patients, and we'll talk about it. If they are on close follow-up with MRI scans, and the trigger trial hopefully will answer this question as well, about patients who have nodal involvement. Obviously, the risk of recurrence is going to be very high in these patients because it's a higher stage tumor. But then with the watch and wait strategy that is coming in, if you on MRI, you've had a complete response, TRG 1 to 2, YMR, then there is a rationale to consider watch and wait for these patients as well. 65-year-old female, anal verge growing 6 centimeter to reach low rectum with inguinal nodes enlarged. Biopsy adenocarcinoma. Now, if for the nodal the regional supply for anus will go into the inguinal lymph node, so that becomes locoregional for anus. But for rectum, the inguinal nodes are metastatic. So and now the question is very, very important, and this is something which we face in the clinic all the time. The question is, how do you treat the patient? Do you treat the patient with radical intent and curative intent? Now, this patient has M1 disease, but also one could argue that the patient has oligometastatic disease because it is less than 3 sites which are involved. So I would say that I would treat this patient with curative intent if it is just one side, but we should also go for inguinal lymph node dissection if your patient is going to undergo surgery, and treat them with as oligometastatic disease. So then to consider single agent CAP or Zelox, 74-year-old male. Okay, so now from the colon cancer trials, the mosaic trials, we've learned that in patients above 70, single agent capecitabine is as good as capecitabine oxaliplatin, and adding a doublet actually makes no difference. So if you're talking of neoadjuvant, I would not add oxaliplatin anyway with radiotherapy, even if they are 50 years of age. But if you are talking of neoadjuvant chemo alone, you can give capecitabine oxaliplatin if the patient is fit, has a normal end organ function. In adjuvant setting, I would consider CAPE alone because, again, I will discuss next week for rectal cancer, we have extrapolated most of the data from colon cancer. And in colon cancer, we know that patients above 70 adding oxaliplatin post-op actually makes no difference at all. But neoadjuvant, our aim is to try and see if we can 6 centimeter, you can actually avoid a stoma. So I would probably give capecitabine oxaliplatin followed by radiotherapy, or give just long course chemoradiotherapy followed by surgery. Then, ma'am, short course versus long course. Short have more acute toxicity. So is it better to go for long course? I mean, I'm not a radiation oncologist, but most of my experience has been that, both of these have their own downsides and upsides. And long-term toxicities are the one which are quite we don't know much about for short course. But otherwise, from all the data we have, I think most of it is it's very well tolerable. And most of the patients after short course, when we have given them chemotherapy, they have tolerated it well as well. So in an elderly gentleman, I might just give capecitabine alone, like I did with this patient who was 84 years of age. But if it was a young patient, I would give them Capox in the interval. Like in the trial, you saw that, the patients got FOLFOX. So what is the experience on observation only post CT-RT? I think I'll discuss that next week. Mainly it's the Brazilian Angelita Habergama data. So
any set of patient who can be taken up for short course RT with immediate surgery and then adjuvant chemo?
Yeah, you can. There's nothing against it, that, you can take them up for short course and followed by immediate surgery. But then, that the chances of pathological complete response are going to be higher if you do delayed surgery. So I think most of us who are treating rectal cancer are now delaying the surgery. And in between, even if you don't give chemotherapy, just delay it anyway. Because, if by delaying it, the chances of your patient undergoing a higher response rate are higher. Then if sphincter is compromised, is it rational to go for short course radiotherapy in these patients? Now, this is a very important question, and we see this so often in our clinic. So patient comes with, they can't even sit. They come with a tire or a tube in the clinic because just even sitting down is so uncomfortable and so painful. And when you examine, the tumor is coming out, the sphincter is involved, they have fecal incontinence. Now, so this is again, this is a personal experience, and this is what most of us do nowadays is I would actually prefer to give this patient something like FOLFOX or FOLFIRINOX as well. Because if it's a young fit patient, because within 3-4 days the symptoms get better, or within a week I would say the patient gets some relief. Now in this patient, if you give radiotherapy, first of all it's going to irritate more, and the symptoms actually get worse before they get better. And in majority of patients, I have seen that, if you're going to give radiotherapy to this patient and not give chemo because, the patient has multiple end organ dysfunctions, then I would advise you to do a covering stoma, because, it will be impossible to hold the patient's hand otherwise throughout the radiotherapy. But I would, if it's a young fit patients, I would give FOLFOXIRI or FOLFIRINOX, and most of the patients actually switch off their disease and they have quite prompt symptom relief. And then, I would give them chemotherapy for 3-4 cycles and then go for short course or long course, whichever you want to go for. So why chemo not given with short course? Again, short course is quite toxic. It's 25 gray per fraction. So it's a very high dose. So that's why I think it's not given. And with long course, I think the dose is 2 gray or 1.5, 1.8 gray. So the dose is less. And the rationale is, it's used as a radiosensitizer. So, so the modulation is better and in increasing the effect of radiotherapy. So then is there any indication for prophylactic colostomy? Yeah, this is the indication I said, if the sphincter is involved, the patient is very uncomfortable, then we would do this prophylactic stoma. either an ileostomy or a colostomy, whatever the surgeon prefers based on the definitive surgery that is planned. So you would do a prophylactic stoma. I always say a stoma because I let the surgeon decide whether they want to do an ileostomy or they want to do a colostomy. Most of the time they do an ileostomy actually, so that, you know, the surgical planes are not disturbed. Yes, you can get the PPT. I'm going to add all of you to this group, and I will put the PPT as a PDF in the group so that you can read the papers. If you need any of the papers, just ask me on the group and I will send it to you. Yeah. And so if patient develops sphincter compromise during NACTRT, should we manage further? So, you know, it's again, this is during the NACTRT, usually they will not develop. Usually it's I think there are various strategies one can employ to so, you know, it depends what the sphincter compromise is. If it's just an anal spasm, you can give some antispasmodics which might help. But if it's tumor related, it's not going to get better unless, you know, the treatment starts working, and then you need a prophylactic stoma.
Ma'am, for the wait and watch approach, which one is better, like short course followed by chemo, or CTRT, after CTRT also concurrent chemo will be given for a longer period?
So, you know, you can only watch and wait those patients who have a higher clinical complete response rate. So whichever strategy leads to the highest clinical complete response rates is better. So I'm just treating a patient on the trigger trial. Actually, she's come from London. She's had her radiotherapy. And now I've given her 6 months of Folfox. After she has completed long course, she's 75. So she has completed long course chemoradiotherapy as part of the trigger study. And now has attained on MRI, her TRG is 1 to 2. And just last month, she has finished 6 months of Folfox. And now she will be just observed. So we don't know the results of the trial yet, that whether this is the right way forward. And I would not recommend that we do that. But again, whichever strategy gets you the highest PathCR rate. And, you know, these are the 4 strategies we've discussed, which can lead to the highest path response rate. And the thing that's most attractive is, you know, the longer interval and filling the gap with the chemotherapy. And again, you know, we know that a lot of times I'm asked, why don't you give RAS wild type? Why should we not give cetuximab or give, you know, full irinotecan? Unless you're giving FOLFIRINOX or FOLFOXIRI, FOLFIRI has no role in early colon cancer because all the trials with irinotecan were negative. All the trials with bevacizumab and cetuximab in early colon cancer were negative. So that is the reason why we don't add irinotecan or FOLFIRI or cetuximab or bevacizumab. So then how many weeks can we delay surgery post neoadjuvant therapy for better PathCR? So, you know, like I said, if your patient is counseled well, and so the time that we delay is about, I tend to do an MRI at 7 to 8 weeks. So let's say a patient has had long course, I would do an MRI at 7 to 8 weeks. We will do the MRI tumor regression grade. And if it is 1 to 2, one can start thinking about what watch and wait, but that is not the standard of care currently. One must remember that. One must explain to the patient, and, you know, only do it with patients who are, you know, completely declining a stoma. But otherwise, and then these patients should be taken up for surgery after, I would say, 6 to 8 weeks. So I would not delay any further because, as you saw in the 11-week trial, there was increased morbidity and surgical complications, patients who waited till 11 weeks. And that is the only very well done randomized clinical trial that we have with about the duration of treatment. So wait and watch approach, is it at present standard of care? No, it is not standard of care. I think we have to individualize in every patient. And and we'll talk more about it, how you select patients for watch and wait and how you follow them up. I think that is very, very important. Okay, I think we're going to stop now. Next week, I'm going to add all of you. I'm going to stay on this for a bit more, and then I will add you to this group. And plus, you can ask anything on that group, and also tell me what after rectal cancer, what you would like me to cover. So we'll finish rectal cancer next week. So we finished neuroendocrine. Now we'll finish rectal cancer. And next, you tell me which topic. In GI cancer. So we'll try and finish GI cancers first, whether you want to do gastric or you want to do hepatocellular or you want to do any other cancers, let me know. Okay, brilliant.
Ma'am, excuse me.
Yeah, tell me.
TRG score you told, how do we do the scoring?
So your radiologist has to do it on MRI. So, you know, if you, wherever you are, like I'm here at Max, so our radiologist has a synoptic reporting template. If you look at the ICMR guidelines, Indian Council of Medical Research guidelines, I chair that committee for colorectal, and we have put the synoptic reporting template in that document for pathology reporting also, and for MRI also. So, and that MRI, if you've done it after neoadjuvant therapy, should give you the TRG. And you know, Dr. Gina Brown does a course, I think twice a year, and it's online as well, available now, how you, and plus Dr. Suprita Arya is there in Bombay. So very important, you know, that you find the right radiologist to make sure that you get the TRG. If you really want to consider watch and wait in your patient, slightly, I would say, with little bit of confidence. It's not standard of care still, so don't get me wrong. But if a patient has an MR like this patient had, you know, and when you see the PAT CR on pathology, it kind of also increases the belief in your radiologist as well. So I think again, this is a learning curve for all of us, including the radiologist as well. Okay. So I'm going to now sit and add. Okay, take care. I will see you next week.
Yes, ma'am. Thank you, ma'am.
Okay, bye-bye. Bye. Oh, Gunjan has been great. She's added a lot of people. Thank you, Gunjan. Thank you so much.